recording this this evening, this morning, this afternoon, because there's some internet stress going on. And Dr. Tova's feeling very anxious, but we're dealing with it. Enough about me. This is going to be a recording we'll put onto our YouTube. We're very excited to be back here with Dr. Bethany Ranes and always with Rose Hoy. Rose in Melbourne.
Hi. Good afternoon from Melbourne.
Get to it with 2 feet, like Dr. Sarno says.
Yes. Now, ladies and gentlemen, we're going to talk about metaphors. And we've got Dr. Bethany Ranes joining us. Now, remember that we had Bethany last week and we talked about the neuroscience. Now we want to talk about the neuroscience of metaphors. It might sound a little bit obtruse, but in actual fact, it's not. I've brought us a sponge. You know, a sponge, ladies and gentlemen, for washing the car. Now, sponges soak up water. But if you put some mud in the water, it'll soak up the muddy water, won't it? Clear water is you're safe, secure, and loved. Muddy water is you're a naughty child. You should have done that. Why didn't you do this? So we soak that up. Bethany, could you explain to the audience how much our brain is active and how many connections are made in those first 6 years of life? And then how that becomes a framework for how we see our lives from there on until we become aware of it. So I've asked you a big question.
That's all right. Yeah. So we make an unbelievable number of connections when we're born and when we're infants in those first few years of life. And so I think I might have briefly talked about last week, one of the big issues too, when you're that young, is you don't have a lot of experiences to draw from. So the experiences that you do have are incredibly powerful. It's kind of like a numbers game, right? Your brain sort of works on things that are likely to be true. It's not sitting there doing calculations by any means, but it definitely goes off of experiences, consistency, things that have happened before that are likely to happen again. When you're little, you don't have a lot of things that have happened before yet. So as things happen, they leave a very strong impression. If they happen consistently, they will leave an incredibly strong impression and just kind of become your basis of reality. Now, you do have phases in those first few years of life. We call it pruning, where you go through your brain.
What's it called?
Pruning, just like a hedge, right? Pruning. And you prune a lot of those connections because you have many, many more connections as an infant and as a small child than you do even as an adult. So we have all of these neural connections and it starts to go through and what do I need and what do I not need? The issue being that what I need, right? Your brain decides what you need based on the power of the connection that's been made, either because of the impact of the experience, the consistency of the experience, or both. And so with language, what I think too is really important, it's not just lived experience that we learn from. Part of what makes humans and other kind of more complex mammals really interesting is we can give each other our lived experience through words and language, which is kind of beautiful. We're not the only ones that can do it. There's research that other animals can too, but essentially our words translate to a form of learned experience to people, children in particular. So if children are told by a trusted adult that something is true, and they're told that, especially if they're told consistently that it's true, that child will make a very strong neural impression and it becomes the basis of their reality. And it does not get pruned, right, as other things may. So things that contradict that may get pruned, which can be problematic in some ways or really wonderful in others, depending on your consistency of message. What's really fascinating too is the more strong those early connections are, the more automatic they become. We don't even realize that they're beliefs. They're just our reality, and they'll affect our perception. They affect our senses. They put a lens on everything that we do and tend to self-reinforce unless you have something powerful enough to break you out of that automatic cycle and help you to kind of notice them, which is not always easy, but completely possible.
So I wanted to say, what could be the powerful enough thing to take you out of that
So a few things. One, especially a context that probably a lot of viewers of this video will understand, a person of great authority telling you or showing you something, a person of great respect. But we a lot of times will notice something or give it a lot more weight if a doctor tells us, right? We might have a very trusted friend that we weigh and they tell us something that we aren't ready to hear, and it can be kind of shocking. Sometimes we just experience something that gets through, and the sensory experience is so different than what we expect that it surprises us. When you feel surprise or shock ever, it's your brain updating. It's your brain noticing and saying like, oops, my prediction wasn't very good. So whatever brings on a feeling of shock or surprise to you, genuine shock or surprise is likely updating those automatic things.
Wow. That's really lovely, because, you know, with ISTDP, it's to put pressure on the person to see it differently, you know, and it creates shock and surprise.
Yes.
So, yeah, because like what we say is that we hope that the patient will have character change, not release of the suffering, whatever, but actual character change. And it's the shock and surprise. So thank you for that, because, you know, I'm doing this for umpteen years, but that part of it, although I do it, I didn't sort of see it from that angle. So, yeah, thank you.
That's literally what shock and surprise are, and a lot of their variations thereof. One of my favorite forms of learning in this case is awe, which all humans experience. And usually awe is an indicator of a fairly large change, a change to a fairly serious neural connection, right? So when you experience awe, it's essentially your brain just kind of has no idea what to do next.
Yes.
It has nothing, it has no predictions for you. And so you're just taking in this raw sensory data. Generally, awe occurs in a sense of safety, right? It's a very positive emotion. You feel safe. You're taking in all these new sensory data. It feels really good because your brain is updating. And the opposite of that is kind of like horror or trauma, where you're not safe, but you have no idea what to do next, and you sort of are shut down, and your brain is taking that in and learning in the same way. But the unpleasant valence or tone of that is a sign that you're not safe. So one is a danger learning, one is a safety learning, but both of them indicate very major changes to beliefs that are going on in your brain.
When there's a danger feeling, that really would indicate that there's no safety with the person that's giving the information.
Yeah, if it comes from speech, if it comes from language, then yes, it's a little harder to achieve awe or trauma or horror, right? However you want to call it, with just language, just because those tend to be a little bit less powerful to our brains than a full sensory immersion. But certainly, anytime there's a traumatic, and I use that term fairly loosely in my field, so it doesn't necessarily have to be like a big T trauma, right? It can be a smaller, consistent trauma. So, not feeling safe, not feeling secure, not feeling, like feeling like you're going to have to be on alert from here on out, right? Like that feeling is what will come from the trauma. So yeah, a complete lack of safety.
Could I just sort of go back a moment and say, if that trauma, like you're a naughty child, comes from someone you love, that's more weighted than someone who you know. Would that be right? Could you talk about that for a moment? Because that's weighted, isn't it?
Very
someone
much so.
That you've got this connection.
I lost the headphone. Let me put it back in really quick. Stupid AirPods. So yes, what that does, so that the problem there is that you have this person's very trusted. So you can think of that person's words now. That person in your mind has been strongly affiliated with like a very consistent or predictive thing. So it's almost like the same idea. You have a very automatic connection with this person and what they're saying and it being true. When they say something that shocks you, that goes against what you expect, it is very weighted, and it can cause a very significant it's more of a social rift in this case, right? It's a little bit more complicated because it's got relationships built into it now. So when it happens to you in an experience, it's fairly straightforward. It still has complexity because of all of your senses and everything that goes on with your environment. But when you add in a relationship factor, God, then you have like environment plus social structure. So
yeah, and then
it can be very difficult. Yeah.
And
so
then you've got pain. The body then speaks, doesn't it? It speaks the shock.
Sure. Well, and that's what's interesting too, is there's lots of ways that pain gets involved with these kinds of things. We talked a little bit last week about, some of how that works. And for many people, it's if you feel pain from a previously very stressful experience, you re-experience that, or a sort of a phantom of that pain. I should use phantom because we talked about phantom limb pain, but kind of a shadow of that pain somehow. Maybe it's similar but mirrored, or it moves, or there's some similarities. But and this I think gets to the heart of a little bit of what you guys are talking about tonight. We also use pain so metaphorically in our language that when you have those shocks, even if you haven't had like an injury or something traumatic physically, it's very possible that you still have a connection between it hurt you when they said that, right? And we have so many metaphors that we tie in between pain. The other thing that happens neuroscientifically, we've done studies where social hurt, so what you're describing, Rose, of somebody that you trust suddenly being untrustworthy, right? Essentially is kind of the heart of that matter. It actually activates the same parts of your brain as physical pain. So things like your nucleus accumbens and your insular cortex and all of those kinds of things react in a very similar way as if you had been physically harmed. We actually have huge overlaps neuroscientifically in those two areas.
Absolutely.
You can see it on an fMRI.
Yes. Now, could I just bring in that, as Tova always says, pain is an emotion. Is that how you say it, Tova? Yes. And this is where this is coming from, this overlap. Yeah.
So is that the study where they I'm sorry, I didn't mean to interrupt.
Yeah, no, it's all right.
Is that the study that they did where they showed a couple different couples were going through rejection in a relationship, and they showed that the brain was firing in the same, because this person was going through a lot of pain and rejection, feeling of hurt, feeling of probably anger, and they showed that it's the same. Is that can you talk about that study?
Yeah, I can. I mean, very broadly, I don't have it right in front of me, but I can definitely share a link to it for the viewers to take a look at it. But yes, it is related to, in this case, the most well-known study is social rejection. But social hurt has broadly been affiliated with it. And I mean, there's multiple reasons for this. I mean, largely, I think it's, this is just me talking now, but evolutionarily speaking,
I want is you talking.
So this is not the researchers talking, but I think a lot of this is evolutionarily. It makes sense because we're such social creatures and we rely so intensely on survival between the connections we have with others, that if you're doing something or something is done to you that breaks that boundary, if you're rejected or if you're insulted or you're hurt, your boundaries are crossed, it makes sense that your brain would take that at the same level of intensity or seriousness as if you did something to hurt your body, because both of them have major implications for survival. So it does, to me, I think it evolutionarily makes a good amount of sense why you would use the same, because a lot of those sub-organs of the brain that are involved in pain, they're learning organs. They're threat and learning organs. And your brain has very few things that just do like one job. And so it's a complex system, and you have to make sure that if even the social threats happening there, you're learning very quickly, strongly from them. And in some cases you overlearn, right? And it becomes problematic. So
that's good. Overlearn. Wow.
Overlearn.
Bethany, wouldn't it be if I'm sad and feeling grief and I lost somebody and I'm crying, and wouldn't that be the same part of the brain that would sense a threat because I'm feeling abandoned, I'm feeling lost, I'm feeling empty, I'm scared?
Sure. Yeah. I mean, it depends. So grief happens, right, in a lot of cases. So you can really put grief down to just the loss of something you had become accustomed to, in something that was helping you, something that supported you in some way. It filled a need for you. And we think of grief when we think of death, of course, and in this case, it's probably the strongest because it's very permanent and it's usually a very close relationship. But you can grieve a job, you can grieve a city
An
after you
animal.
move.
People who grieve an
Oh,
animal
of
dying
course.
can be very.
God, I've grieved really hard over animals, right? Like, I mean, absolutely. And so grief is really kind of our lived experience of losing something that was very important to us and that we likely, again, automated quite a bit, and it was a support and it offered something to us. And sometimes you can't even put your finger on what it was. If it was so embedded, you might not even know what it was giving you, or that you would have that grief response. It might be a complete surprise to you. But in other cases you do, and you anticipate it. But yeah, the grief response is usually an indicator that you've lost a very important coping or support thing in your life, be it relationship, person, place, whatever.
I've got a feeling, but I might not be right. But if you have grief, like someone very close to you dies, I've got a feeling that somatic pain drops away. As you allow the grief to come up, the somatic pain drops because the whole body goes into that grief and they don't need to defend against the grief. Yeah?
It depends. It really would depend on your own associations. So grief most certainly is associated with more depressive symptoms, a shutting down. Part of that is, so I hope this isn't too much of a tangent, but this is something I find really interesting. So if you look at depression and depressive symptoms, and you look at something that doctors call sickness behavior. Are you guys familiar when I say sickness behavior, what I mean by that?
Want to say it again?
Sickness behavior. So when you have an injury or a pathogen, something that's very structural in nature, you express, most animals, and people are no different, will present or demonstrate what are called sickness behaviors. There are particular behaviors that exist to help you rest and recover. You don't necessarily sleep a lot, right? It's not like a sleepiness, although you can sleep more, but it's more of just an ennui, a feeling, just a nothing. Like you don't really have a lot of, you don't have a lot of strong emotions, or maybe you feel some sadness here or there, it flashes through. But sickness behaviors and depression look very similar. And then I've always thought that was really interesting because it tells me that when people are experiencing depression, what we're looking at is something's going on and their body is getting a signal, much like pain, where it's like, hey, danger signal, stop what you're doing. Depression is a less intense, a less like acute version of that, where it's like, hey, stop what you're doing and we got to heal. But most people who have depression aren't ever taught that. They're not even, they're kind of taught, oh, it's sadness or it's emotional or whatever. And let's block it, right? Like we'll block those symptoms.
Instead of allowing it to come up. Yeah.
Yeah. Let's figure out what's causing those symptoms is really the question we want to ask. And what research has found is there's all kinds of things, systemic inflation, and kind of like chronic issues, like little lifestyle behaviors that can have like small but persistent effects on your body and its functioning. A lot of those things tie in to depression. So it's really interesting. So with grief, you may feel depression, and a lot of people do, but you may have different associations, and that's why I think we have the stages of grief, because it really is a complex thing. So depression's maybe a small part of it for people, but there's also things like physical pain for some people. There's anger, obviously, is a normal response to grief. And denial, of course. We don't want to change. Our brains are energy savers. They don't want to have to give up something that they've had for so long. So your brain's going to deny it as much as possible. So all of those things are really interesting. So when you think of all of the grief responses, they all make a lot of sense as to how they work. But most people don't feel somatic pain as part of a grief response. But of course, if you've got some kind of an association, a fear, it could trigger pain for some people if there's a fear response associated with their grief. So it really kind of depends. But depression does tend to dampen physical responses in most cases, but certainly not all. There are plenty of people with comorbid depression and chronic pain. So gotta love the brain. There's never like one answer. It's always like, it depends.
That's right. Now, in our preparation for today, I found this guy called David Butler. Now, David Butler talks about metaphors. Very, very good. And I know we don't have a live audience at the moment, which is such a shame, because I brought up all these different metaphors. Now, remember that many of these metaphors are ontological. I haven't said it properly. But anyway, which means it gives it gives something that's abstract solidity or a voice, whichever way you want to put it. Now, looking for direction, I'm at a crossroad. This is an example. Invasive metaphor, it's like a knife in my side. Understanding a prognostic metaphor. My neck is totally effed. It's rooted. And the disembodiment metaphor is, I want a new one. I want a new back. And this is one of the things that we hear often. A disembodiment feeling about our pain. Wow. I don't want my body. I don't want to be that person anymore. Bethany, can you draw that in to neuroscience for us if you can? I know it's sort of a bit obtruse, but it's very important for patients to know that this is part of that mechanism that blocks away their feelings somehow. Can you draw that in? I didn't give Bethany any background about what I was going to ask, by the way, guys.
I was going to say, I knew it had something to do with language from last week. I'm just guessing in the dark here. If I'm wrong, I promise I will fix it. But no, actually, this one I can do. It does seem very obtuse. It seems very abstract and strange, and I think most people would poo-poo it and be like, "What? That I don't know about that." But if you think about what I was saying before, that language is sort of like the Diet Coke of experience, right? It's not always as strong as a fully immersive sensory experience, but it still is powerful enough to change our neural connections. And it's affected by, again, the power of who says it, but it's also affected by the clarity and the ability to internalize the message of what you're hearing. And what these metaphors are doing is when you say you're taking something abstract and making it concrete, another way of saying that is you're adding sensory details to it. You're making it more like a sensory experience for a person by taking it and putting it in a sensory experience you're familiar with. You've seen a crossroads, right? You know what when I say a crossroads, you can look at that. All those things you just talked about were highly sensory, and that is no different here. Pain is used very often as a sensory metaphor for other things, and it builds the association, and it can build it fairly strongly if you're consistently doing it all the time. So the disembodiment one is very interesting because it takes something that is physically impossible and puts it in language that almost feels possible, particularly in our Western culture where if something breaks, you get a new one, right? Like we're terrible about that. We've become so accustomed to just replacement. So what you're doing is you're taking the familiarity that you have, whether it's conscious or unconscious, with this idea of when something breaks, you fix it, you get a new one, you replace it. And you're applying that same sensory clarity to something that unfortunately just will not work that way. And it creates a dissonance, right? And it's going to create an issue where you want for this more and more and more, and you may fixate on it more and more and more. And in some cases, it may lead people to get an unnecessary surgery where they do try and replace it, right? my knee is messed up, I need a new one. And in a lot of cases, that's actually not, it doesn't help. A lot of people, unfortunately, have to learn that the hard way. They spend a lot of money, at least in the United States. You have a lot of money and you do these surgeries and the pain comes back. It takes a while, but it does come back. Because essentially when you get down to the heart of it, that surgery was a placebo, right? For a lot of people, unfortunately. And that's where the effects come from. If they come back, you know that it wasn't structural. So what's happening is you're taking language, which already has power, and you're boosting it with a metaphor, and you're making it sensory.
Yes, you're boosting it.
You're boosting it. Yes. They boost the power of the language. So when you're making your neural connections, they are that much stronger because you now associate it with those things in the metaphor. So you'll always have like a little mental image that goes with it because, like you say, it's so funny because here's an example. You said whenever you're looking for direction, you look for a crossroads, your first example. When you said that, of course, I've heard that saying a million times, but I see a very specific crossroads. I can even tell you it was from whenever I was driving a little motorcycle scooter Vespa back when I lived in California, and I drove it down the length of the Central Valley, and I stopped at this crossroads in the middle of nowhere in the morning, and I just remember thinking, like, this is the most crossroads I have ever seen in my life. It was like almost Faustian, like it was just very much a perfect crossroad. And so anytime somebody uses that metaphor, like I have a flash of that memory. So in a weird way, my brain is going to associate that metaphor with like riding a Vespa and like driving a road trip. And everybody has these funny little things. I mean, most of the time you're not ever going to be able to tie that back to a specific memory. I don't know why I have that one that's specific to me, but it's really fascinating how it ties into these sensory experiences that you have, and then it draws from the power of those, right? And becomes that much.
I could be at the crossroad and be like, oh, I can't make a decision. I don't know what to do. Where should I go?
That's right. Yeah.
Like but the brown fuzzy bear.
Yeah. But it could also now tie back into that crossroad of being in pain as a kid or a teenager, and the puzzlement with mum or dad, or being taken to the doctors. How many patients tell us that they've been to 10 doctors and all the doctors are puzzled? But we're not interested in what the doctor's prognosis or story is. We always go back to what the patient feels. Because this sensory thing, this reminder, is almost of this powerful person not knowing. And then I'm at a crossroads about my back pain. Do I go to the orthopedic surgeon or do I look at my emotions? Isn't that the crossroads?
Yeah, absolutely.
Patients. Yeah.
A lot of it, I think too, it's just, and I think there's language too, that what's really important to remember, whenever we give like a very hard you statement and we associate something with someone's sense of self, you become the metaphor for something yourself.
That's right.
And that's a really hard one to break. So that's getting back to your muddy sponge.
You become a metaphor? I don't
know. So if somebody tells you that you are, I would imagine a lot of folks at watching this have been told they're sensitive. You're too sensitive. You're just too sensitive. You need to get over it.
Yeah.
That's the mud. That's the mud.
And what's happening is like now you've taken like this you're too sensitive, and you are the concrete example. Because if you've been told that enough times, if you've been told that by trusted people, whether it's parents or doctors or whoever it may be, you've now tied it to your sense of self. And like, I am sensitive, like sensitive is me kind of a thing. So and those are,
and that
those
equals
are particularly,
that equals I'm a problem. I am a problem.
Yeah.
I
am this.
Yes.
And it's very hard to maintain a sense of recovery or change when you tie something to yourself as the metaphor. Like your concrete example of an abstract thing is you. That's really rough. And we have there's a part of the brain that is, has, again, lots of jobs, but it seems to like kind of hold our sense of self, and it's called your default mode network. it's been super popular for like 15, 20 years now in neuroscience, almost like a cliche. Everybody wants to study the default mode network, but it's kind of this no man's land of your brain, and it's like the ongoing function, and it's what you study usually in things like a resting state fMRI, where you're doing nothing. You do nothing at all. You're just sitting there daydreaming, imagining, whatever, and you have a lot of things there that are tied, we see, to our sense of self. And so all of those things are tied in neurally, and they're wired in there. And so if you've got something that's tied into that default mode network, it's like your reflection, recognizing yourself in a mirror. What do you put there? And a lot of that is built through the sponge metaphor that Rose used. If you have mud there, it's very hard to get it out. Imagine that mud being inside the sponge, right? Like it's in
That's
there,
right.
it's deep. And
it can be safe, secure, and loved, clear water, or it can be muddy. You're the problem.
And if you have like a really deep mud, like if you just like get it really in there, squirting it with clear water on the outside is not going to cut it. You're not going to get it out of there. So
I used to walk into a therapist's office when I was a teenager and say, "Can you make me not sensitive? I need a skin like an alligator," because that's all I heard growing up.
Yeah.
And the therapist was like, "What do you mean?" And I was like, "Yeah, I need you to like change." And I was really serious about that. And it took me years and years and years to, of course, channel that sensitivity. And many people we know have been pointed at and told, as opposed to, wow, what an amazing characteristic, your sensitivity. But
we've lost you,
the
Tova.
book, when the body,
we got you back.
When the body says no, it's because you're always saying yes. So here's this another metaphor of, I'm out here saying, yes, I'm a good person. I'm a nice person. I can do this. I can handle this. I can handle that. Yes, yes, yes. And my body's saying, no, no,
Back
no.
off.
That's another deeper, a deeper thing of what Rose is saying.
Oh, yeah. I mean, that's a really common one in most of the really great therapies we see for a brain-based approach to pain is people pleasing and not listening to your body. Right? I mean, it's if it's not part of your therapy, you probably want it to be paying attention to those signals. And I think that's what happens. Your brain just starts to rely more and more. It has to pull the e-brake, right? And what are our e-brakes? Pain, depression, right? Those are the shutdown levers, because we're trying to push through things. And unfortunately, again, a lot of those things come from these beliefs that we have that are like us. One of the most heartbreaking things I see, and you hear it a lot with pain, is I will always be in pain. I am always going to live in pain. I am a pain patient. You see it a lot with depression, and you see a lot with addiction. That's always heartbreaking for me when people are just like, I am an addict, or I am depressed. And I think it's where we talk about patient-centered language, and we know it's important, but I don't think we talk about why it's important. And I think a lot of that is getting away from using yourself as the metaphor for a condition that you're experiencing in this moment. You aren't that thing. You aren't this. And you need to make sure that you have a distinct sense of self that doesn't involve pathology. You don't want to have anything like pain or depression or addiction, something that you're struggling with in the moment, to become part of that default mode network of like, this is just who I am. Because it's really, again, really hard to get past recovery if you think it's just who you are. So that for me is a big one.
Can you tell us why that happens? Because we call it, I can't think of the word now, that we're fixed to it. We're fixed to that. Can you talk about that for a minute? Because that fixation is not accurate.
No.
I mean, no.
But no, those are
tied to it. Yeah.
Well, and they've been told they're permanent conditions, to be fair to people, right? Like a lot of people think they're going to be in pain forever because they've been told they'll be in pain forever. People think they're addicts forever because they've been told they're going to be addicts forever. People think they're going to be depressed forever because they've been told that. And the list goes on and on and on. And what it does is when it becomes who you are, it really automates. you don't think about it anymore. It's just a part of who you are, and you stop thinking about it as a changeable thing. Some of the stronger beliefs about the self and the default mode network are some of the hardest neural pathways to change that there can be, because you're generally unaware of them consciously most of the time. And once you do become conscious of them, I mean, they're just so reinforced. It takes a lot of sensory data and evidence to change them. A good example is just you can see your nose 100% of the time, 24/7. It is always in your field of view. But you've gotten so used to it just being a part of who you are, and it's not important and it doesn't affect you. You don't see it in your field of vision.
Yes.
Yeah, it's 100% you're blind to it, right? So if I had to tell you like something about that, it's really just, without crossing your eyes, it's really hard just to see your own nose in front of your face, which another metaphor. But your self beliefs become just as invisible to you. It doesn't mean your nose is gone. It's still there and it's still functioning. One of the ways, and this is a different topic, and definitely if you're interested, it's one I find really fascinating, but they're looking at clinical uses for psychedelic medications, which is a very big thing in neuroscience and psychiatry right now. What all of the major psychedelics do is they change the brain to where the default mode network becomes more open to change. So it releases chemicals in the brain so that the default mode network becomes more flexible. It increases what we call neuroplasticity in that part of your brain in particular.
So what does it release?
So it helps you have to do it. This is me. Some people will say it differently, but I stand by this hard. You have to do it with therapy. You can't just take these things and wish the best, because what happens...
Monash University are doing that at the moment. And one of our guests is one of the lead psychologists in that. But what's the release in the brain?
It's a softening of your core beliefs. Suddenly, what happens? Let's see. I'm gonna put this in
core beliefs.
It softens them and it makes them more changeable.
Yeah.
It essentially takes. When I say you have really strong neural pathways and you have weaker ones, and we've talked about the trail metaphor, right? Like some trails are roads and some trails are barely visible. What a psychedelic sort of does is it makes all of them the same strength. It takes that weighted system, throws it out the window. Everything that you have is equally possible. And that affects things like what you see and everything. And it's what you believe. And if you work with a therapist in those moments after, where your beliefs are softened, you can actually start to change them a bit more dramatically and faster, because you don't need as much sensory data to change them. They become more plastic. They become more flexible. So you can do a bit more with them. So when you have things that are associated with the self, that is essentially what those drugs are. I mean, at a very high level, that is what a lot of those drugs are doing.
So what exactly is released in the brain to create that?
You meant literally. Yes. Literally. So there's a couple of different chemicals that work here. A big one is dopamine.
Right.
So it works largely. There's others as well. All of them have different kind of side. I don't want to call them side effects, because they're actually very helpful, and we use them for clinical selection. Like Mdma has certain chemicals. It's usually quite a few, but they work on things like oxytocin. Psychedelics work on your endogenous opioid systems. They work, but largely dopamine is what kind of handles the weighting of, is this more likely than this? So dopamine's a big one, but of course dopamine does everything. It's like saying serotonin or anything else. But they go in and they affect the regulation of these things in a very systemic way, as opposed to being like a really specific molecule, which is what we usually see in these kinds of drugs. And actually it's really a good thing in this case, because the entire process is so large. There's really nothing, like I said earlier, there's no one answer to brain issues. It depends. It's functional.
Yeah, in my younger days, the patients used to have LSD.
Yes. LSD is a really strong one. So it's not used clinically as often just because it's kind of bringing like a Mac truck where you could use a geometro sort of a situation. Ketamine is currently very popular because it's already FDA approved here in the United States. Ketamine works in the same way I said. All of them kind of work on the default mode network. That's how you know. That's the psychedelic experience. So if something gives you a psychedelic experience, it's working on your default mode network. But ketamine also helps with inflammation and can help with immediately help with suicidality in a lot of people who have suicidal tendencies or thoughts as a result of inflammation. Mdma is amazing for PTSD. It works on the amygdala and it works on a lot of your threat learning and helps soften those things so that you can kind of, if you've overlearned something because of trauma, what these drugs can help you do is bring it back and relearn it at a more appropriate level. So it's really cool. It's essentially kind of like a little magic eraser for problematic things.
Yeah, for the punitive superego part. Look, in this, can you tell us a little bit about how SSRIs work? Because many patients have suicidal ideation with them, don't they?
Yes, they do. Yeah. So I should probably have a bit of a disclaimer. I am not a huge supporter of SSRIs in the way that they're used currently. They're based. Okay. Just want to make sure that we're good.
Yeah, I know. They're terrible. Yeah.
So I've long been a bit of a decrier of SSRIs, partly because the serotonin hypothesis of depression has long been an issue. Neuroscience has not shown support for this, and it's clearly not the cause of depression. Depression is, again, it's a systemic thing. It's actually, I think, it's a healthy reaction in a healthy person. It's what we see with sickness behaviors and lots of things, but we aren't doing a good job of finding what's causing it. And so it looks, and maybe it's going off on again, like kind of like pain, where maybe it is a problematic activation, but we need to deal with that, not the depression symptoms. Exactly. SSRIs, for those who don't know, it stands for selective serotonin reuptake inhibitor. And what it does is whenever your brain has a dump of a neurotransmitter, you have reuptake where you suck it back in like a vacuum. SSRIs block the vacuum hoses that would take it out and kind of keeps the serotonin level in your brain high longer. There's problems with this. One, doesn't even work to resolve symptoms for a lot of people in their depression.
It clouds it. It clouds it on them.
It usually works for some people on some things, sometimes. It does not have consistent results. The other problem being when you artificially mess with the balance of one of your neurotransmitters, particularly serotonin is one of your major neurotransmitters, a monoamine neurotransmitter, it starts to tell your brain, oh, I have a whole bunch of this. I have too much of this. I don't need to make it anymore. I don't need to keep making this. I have too much. I need to slow down. It sends the wrong signals. So early on, it can quite quickly, but most certainly over time, it affects your brain's ability to naturally regulate your serotonin. So what really upsets me with SSRIs is not only that they're not consistent, they can't be explained in their mechanism of action very clearly when you look at neuroscience research. People are put on them for an ungodly long time. And when you're put on something like that for a really long time, it really has a major impact on your brain's natural ability to regulate a very important chemical. And there's a reason that you can't just stop taking it because you've completely altered your brain's regulation of this chemical. Now, when it comes to suicidality, there's a couple of there's not an exact understanding of why that is, but it does increase suicidality, particularly in younger people. And what happens, what has long since been like kind of a hypothesis for that, is that when you're depressed, you are really down, you're blunted, kind of unmotivated and lethargic and fatigued, and everything is sort of foggy. And when you start taking an SSRI in the early days of that slowly clearing up, you may have more suicidal tendencies and ideation because of those changes, that you haven't had a mood shift but you had sort of like an energy shift or a clarity shift or something like that. That is one way. I'm not 100% sure how strong that has held up, but I know that when I was in school, like that's what they would teach you. To be very careful when someone went on an SSRI or an antidepressant medication, because they would potentially be a suicide risk. We also know that suicidality has a lot to do with inflammatory issues in the brain, and issues with regulating the inflammation in the brain, which is why, again, we see ketamine kind of knock it out pretty quickly, because it acts on those things. So what I also wonder myself, again, this is Bethany talking, and not that, like, I'm not quoting a study, so take it with a grain of salt.
Question mark, yep.
Please question mark this. But when you have something that's vastly changing the regulation of a major chemical in your brain, it's very likely you're going to have some kind of an immune response in other parts of your brain to something that significant. So I would imagine that some of those inflammatory mechanisms for suicidality might be triggered when all of a sudden, your brain is having very unusual behavior with a critical neurotransmitter. So it's possible that immune reaction is happening because you had a sudden change in the brain, and it's reacting to that, which can potentially lead to some suicidal ideation or tendencies there too. So that's kind of my 2 cents on it. I definitely now ketamine doesn't work for all people with suicidal ideation, sadly. So we know that there's multiple pathways. Not everybody has an inflammatory pathway for suicidality, and the reasons for it are largely still, not well understood. But for many people, it is an inflammatory issue, and that's why the ketamine therapy has been so effective for that. So that's pretty exciting for me, just because it's the first time we've had something that, like, in one dose, you see a response, right? Changes it right there.
Yeah. Now, if you think about it, what we've been talking about is how we position ourselves in our thoughts to create our pain, to develop our pain, and to develop the idea that we can never be pain-free. So just to sort of like draw it all together, that whole notion that our thoughts, our metaphors are all part of that sense in the brain that says, I am what? I am the pain.
Yep.
I am,
I am a patient, right? Like,
yes.
Yeah. I am a victim of my pain. I always will be. It's one of the first things. I am desperate. Yeah, absolutely.
Yeah, I've got heaps of them. I'm going to pieces.
So we're really down to community. We're down to communication. We're down to communication.
Communication is critical. I think that, and this is a beautiful topic to draw attention to it, is that I think communication is super underrated in this field, because you have to be an effective communicator to undo the damage of things we've unintentionally been very effective at communicating, problematic things. I've told the story a lot of times, and probably already told it on here, of working, being in a session. I am not a therapist, so but kind of sitting with one of my clinicians, and I believe it was a young woman who was, I don't even think she was 21. I think she was like 19 or 20 years old. She'd been in a car accident, went to the ER, and the first thing the doctor told her is that she would be in pain for the rest of her life. Why would you ever tell an 18-year-old kid that they're going to be in pain for the rest of their life? How would you don't even know. What would drive you to say such a thing? And she had completely internalized that. That was a very effective communication of a very problematic belief. And we do that, unfortunately, pretty often. And one of the things that I think is missing when I see this, and not from everyone, there's some very talented people out there whose communication skills are amazing. But I think largely where this falls flat is that a lot of clinicians don't have the time to communicate effectively, and they don't know how to do it quickly, and they just don't have those skills. They're just kind of not sure what to say.
It's a skill problem, because even if you've only got 10 minutes, that 10 minutes can cut to the bone.
Yep. Certainly you can do a lot of harm in 10 minutes. So we need to be able to do a lot of good in 10 minutes.
Yes, that's what I mean. You can get into the pain, into the
Yeah,
bone.
absolutely. Yeah, and so I think that that's actually, it's something that like is assumed that if you know how these things work, you can communicate it effectively, and that is obviously not true. And it's
That's
hard.
right.
It's hard to communicate it effectively. So
Yeah.
I really commend people who focus on the communication side of this.
Yes, and also remember that the communication is a part of attachment, a part of rejoining the person to their community, and by reframing, it joins them back to their community, and then the sponge can be washed out.
I love it. Bringing it back to the sponge. Yeah, absolutely. Language is powerful. It's how we connect. I mean, God, look at what we're doing right now.
Exactly.
Like how powerful is this right now? And we're in totally different parts of the globe, and people are going to be watching it from totally different parts of the globe, and yet it still has an impact through
And then
communication and language.
we're going back to like if we can teach, we can guide our clients and our patients to be more mindful, to be more aware, to stop and think before they speak, to themselves, and all that kind of like self-reflection.
You've got to bring in the or part. And that's what's missing in many, many, many of the therapies, that shock that you've got to bring in, that your way of thinking has not been helpful.
Yeah. That aha moment, right? This is what's called in therapy a lot of the time.
And that's why I love what I do, because it's built in from the moment you meet the patient. It's built into the session.
Yeah.
So yeah, Bethany, we need to finish up, but there's something that's dear to my heart, and that is the poor people with Alzheimer's disease.
Oh yeah, yeah.
Is there any research there? Because I know there's been a small research done in Norway, with ISTDP and people with Alzheimer's. But of course, it's not a glamorous thing, and it's always, people over 70 type thing, although people in their 40s get it as well. And one of my questions I always ask family members when I see an Alzheimer's patient is, are they an anxious type? And mostly they'll say, yes, they've been anxious all their lives. And this connection, I mean, I'm just an ordinary person, well, a nurse, but, like an ordinary individual person.
You're anything but ordinary, Rose. I'd be hanging out with somebody who was just ordinary? You are extraordinary.
Okay, but I want to know if Bethany knows if there's any of this sort of research happening, because, when I've read about it, the TORs, like if you've got cortisol pouring into your brain or from your brain all the time, the TORs there's no space. We were saying before about emotions and pain being of the same genre. Well, I'm wondering about Alzheimer's and how that, is affected, because Alzheimer's is also TMS.
Yeah. So dementia in general, but Alzheimer's, there's a huge connection between anxiety, depression, and Alzheimer's later in life, or dementia more broadly. There's also a really big connection in other disorders like diabetes and dementias and Alzheimer's.
Absolutely.
That drew attention to me because those are, and I bang the inflammation drum more often than I should. I get, because it's like saying, oh, oxygen causes the problem, but they're inflammatory. They're systemic inflammatory conditions. Exactly. Your immune system is always on alert, right? So one of the things that I find interesting, so there's tau, and there's questions that have recently come up around tau's involvement with Alzheimer's, because there's been some questions about the original research that was done being potentially not viable. I believe a very seminal early article from Nature was recently pulled. I don't know a lot about that field, and I don't want to speak too much outside of my area there, but I know that was a very big news story just a few weeks ago.
I missed that, but that makes sense to me.
Take a look at that. There was some questions there. It's not been replicated, right? And drug studies have been massively ineffective following a lot of those early hypotheses. Getting back to the inflammatory stuff, what I found interesting, so your brain has its own little immune response, and it's largely affected by type of cell called microglia. And so microglia are different than the long, skinny brain cells that we think of, right? They're different than a neuron. And they're more like a white blood cell, but they live in your brain. And I like to think of them as the National Guard of your brain. And that's for two reasons.
White cells especially attuned to the brain. Oh my God, Bethany, you are awesome. I mean,
so yeah, they're these they're called microglia.
Microglia are the security guard.
They're all through, and they're like a National Guard. So here in the United States, we have a special part of the military called the National Guard. When they are not deployed, they're in charge of all kinds of community help. They help with roads, they help with disasters, they clean up after hurricanes and weather. They're incredibly useful internally. They're a big part of our internal infrastructure system, right? They come in during emergencies. They help. They're really great. And they just kind of help out. But then when there's war, they're deployed just like a troop, right? They go off to war.
Okay. I didn't realize. Wow.
Yeah. So microglia, in my mind, are kind of the National Guard. When you have some kind of immune emergency going on, or something is emergently important, and you need an inflammatory response in the brain to protect it, microglia do that job. When microglia are not being, deployed overseas, they clean up. They're responsible for cleaning up and pruning old bits of neuron, connections. They make sure your synaptic connections are clean. They clean up old neurons. They have a big role in kind of keeping your brain clean, keeping your brain maintained physically. And they go through and do a lot of cellular, because they are capable of digesting, and cleaning up the cells. So they do that, and it kind of helps your brain just function well, properly, making sure that you're making new cells as you need them and making new connections as you need them, and there's not just dead parts, out there floating around. When you're always on high alert, your immune system is always going to be activated in some way, slightly to severely. It all depends. People's somatic responses are a little different. For some people, I think that they have this ongoing life immune activation. And in neuroscience, when your microglia are activated, we call it microglial activation. And it affects your neuroplasticity, it affects your brain health, it affects a lot of things. And so for me, I think it's really interesting. There's a lot of connection between that microglial activation and the formation of dementias later on. And I believe there's a connection with Alzheimer's as well. So what I think for some people may also be happening is that their National Guard is never not deployed. Their National Guard is never home. So all the maintenance is being kind of, disregarded and deprioritized. So you start to have physical, structural degradation in the brain. So with certain dementias, it can be reversed, right? There's some animal studies coming out. They're seeing some improvements. There's things that can be done. Very, very early stage. There's nothing out there for humans that I've heard of yet, but they're looking at this as a pathway. With Alzheimer's, usually you have pretty severe structural damage to the brain. To what extent that's reversible, I don't know. But when you're talking about TMS style therapies, what you're doing is you're bringing that immune system out of high alert. Your body's immune system, your body's reaction, all those danger signals, turning them off. You're learning to turn them off. And I think microglial activation is one of those danger systems as well. So when you're turning off all the other danger systems in your body, you're also bringing your microglia back home, right? They're calling them down so that they're not so worried about invaders and pathogens or problems, and they're focusing more on the maintenance that you need and the things you need to keep your brain healthy.
Bethany, you guys are amazing. You and your colleagues, you're absolutely
amazing. That's all my colleagues. That is not me.
The Bethany Ranes show once a month. Bethany, I hope you'll have time for us, because I know you're going to get a little busy in the next few. Maybe we'll be your comic relief.
Well, I'll tell you, this stuff I find it so amazing, and honestly, this work is all over the place. This is all just me being a fan of other people's work, I assure you. But it's it's pretty amazing. And again, you know, I want to say Alzheimer's is something, again, it's very complex. So this isn't the only pathway to it, but there's been a lot better work, I think, looking at what you would call a functional biomarker, as opposed to like these like very specific, we were looking like for the Alzheimer's gene, right? Or things like that. And certainly there are genetic traits or genetic types that are more prone to Alzheimer's. But I really love the research that looks at things functionally, like this microglial activation work, because it's like, okay, it doesn't just happen, right? It doesn't just turn on.
Yeah.
Something's happening to build this up. What is it? What's the function of things going on? Doing kind of more of that, you know, kind of inductive, that more, this AirPod just doesn't stay in today, more constructive research, as opposed to the deductive, like, well, let's start at Alzheimer's and try and break it down. You start to run into issues there. But when you start with like, how does the brain work, and let's build it up, and you meet in the middle, it really gives you cool ideas.
I'd like to kind of round it out and say, because I have a book by my bed about the telomeres,
Oh, telomeres. Yeah, the telomere effect. Yeah.
You know, I want to say, like, on the record, that aging is a disease. It's not to be expected, and we can participate in how we age, what we age, who we can participate in every way we can, just by what you're saying, and affect our telomeres. We can affect ourselves. We can do the best we can without judgment, without criticism, in aging gracefully and dying, like we say, like a candle goes out, like the light goes out, like peacefully, with or without Alzheimer's. And I think what you're giving us is the choice. We have a choice. We have an attitude. We have a mindset. We have a way we can go into aging as we age, the way we communicate to ourselves, the way we communicate to our body. And this is a whole nother topic about disease and about aging and about sickness and about, because it's basically, you know, you bring up the word genetics, which is another whole topic of like, my life is not predetermined, and neither is yours or Rose's.
No, I actually learned a lot about genetics from some amazing colleagues I had a few years ago, about just even your genetics aren't really like your genetics. They express, they turn on and off, they methylate, they change. Yeah, it's really amazing. So I actually had some really brilliant genomics professionals kind of walk me through, like hold my hand, like Mr. Rogers, and explain some of these things to me. But and I'm still like, it is, most of that stuff goes way above my head, but I found it very fascinating and kind of very liberating that, like, you know, you aren't this perfectly blueprinted thing, and that things change. So yeah, absolutely. And I think too, you know, it kind of gets back to that I statement, right, Tova? Like, you know, you change, you can evolve. You are not broken.
We call it character change. We call it character change.
You can change that character anytime you want, and it can be hard, and you'll need help, and you need support, and you need consistency. It's not easy. It's not like, oh, today I'm going to be this, a genetic scientist. But you know, it's that consistency and that support over time really will change physical things about your brain and body. It's really amazing. And so it's really important, not just what you surround yourself with, but also like what internally you're reinforcing all the
time.
Amazing.
Bethany, thank you so much for a very, very awesome discussion. And I'm so disappointed that we don't have our audience, because it would just,
I know.
I would have loved it. I have got a whole page.
Well, let's do it again. I want to repeat this. This is everything that Bethany said, and Rose, that you said. But Rose, you said amazing things. We're going to repeat this, and I think we need to bring this show back, this topic back again, in maybe next month. You know,
no, not for at least 6 or 9 months.
But who knows? Like I said, Bethany may need some comic relief, and we may just be that for her.
Oh, okay.
Her mother loves our shows.
Shout out to my mom. Yeah, she loves you guys. She adores these shows. I'm pretty sure she's watching them whether I'm on them or not.
I think we need to have a once a month grieve with Bethany, and I think we can do it. I'll talk to Rose. We'll have a board meeting. Maybe we'll see in a few months. And there's so much to talk about, such richness in this topic. Thank you, Rose, also for bringing this back. It was your idea. Rose, you're brilliant. You're extraordinary, Rose. I love you. So we're gonna say goodbye. I I may go back to
As
bed or
of
go back to work.
Yes.
both my colleagues here.
Yes. Wonderful. Have a wonderful night, Bethany. Sleep well, Rose. Have a wonderful day. All the best.
Thank you.
Bye.
Bye, you guys.
Stop recording.